Well, good evening, everyone, and thanks so much for making time to be with us this evening as part of the webinar series run by the ANZ Audits of Surgical Mortality. We are meeting this evening on behalf of the Queensland and Northern Territory Audits of Surgical Mortality, and this evening we'll be discussing the medico-legal aspects of futile care. I'd just like to commence by acknowledging the traditional owners upon the many lands that we're meeting on this evening, past, present, and emerging. And once again, thank the ANZ Audits of Surgical Mortality, the College of Surgeons, and more locally, the Queensland and Northern Territory Health Services for supporting the audits of surgical mortality. We'll briefly touch on the reasons why we're here this evening. And at the very core of the audits of surgical mortality, we're reliant upon the many reviewers who provide us with very useful commentary and insights into the cases that we review. And this is one quote from a recent case that I'll just leave you to read. And this is at the very heart of why we're discussing this issue tonight. Now, this evening I'll be your chair, and with us we have an invited speaker, Holly Ahern, General Counsel for Metro South Health, who has over greater than 10 years experience as a lawyer supporting the delivery of public health care in Queensland. She enjoys working in health with a focus on people and understands the legal landscape and has unique perspectives of whole of system challenges and areas of legal risk. Now, Holly and her team advise on all aspects of health law and medico-legal matters, capacity, end-of-life decisions, coronial investigations, inquests, police statements, personal injury claims, to name but a few, and regularly advises hospitals and health services and executive leadership teams, has worked as a counsel assisting the Coroner's Court and Coronial Registrar. So obviously a very experienced individual, and we thank her for being with us tonight to provide some medico-legal insights into some of the clinical matters we'll discuss tonight. We're also joined by a surgeon, Dr. Michael Auld, on the panel, who will be providing some insights into the clinical matters. Michael's the current Director of Surgery at West Moreton Health Service, is a general surgeon with active acute surgical unit responsibilities, and is a keen and interested QASM reviewer and a member of the newly established Query initiative through Queensland Health as a subject matter expert in all things surgery. So thanks, Michael, for being with us tonight. So those of us who are expected to fill out surgical case forms on the odd occasion would be familiar with the data fields that are required. And here we see question 11, and this relates to the surgeon's view of the overall risk of death. And as you can see, expected and futile are data fields that we reflect upon when filling out this form. And if we have a look at some ANZ audits of surgical mortality data over the last 5 years, we can see there's been a slight uptrend in the absolute numbers of expected and futile deaths over that period. And this is also not just a figment of our imagination, with a relative increase in these numbers of cases when considered as a whole over the total number of mortalities that are observed through the audits of mortality. But this isn't just specific or unique to surgery. And our sister group, Gundara, an anaesthetic group that are based in New South Wales, have also noticed this trend over time. And this audit over a 10-year period, published relatively recently, also captured this notion of futile surgery, with their quote being, "Just because we can, it doesn't mean we should." And I think that's quite poignant. As mentioned, a slight uptrend in the numbers of cases considered futile over this period of time. So I think it's important to just define some of the terms we'll be discussing this evening. So what is futility? Well, in essence, it's the absence of benefit. Treatment futility, when treatment does not achieve the intended goal. It's not a clinical concept, nor is it a legal or bioethical one, but in essence it boils down to non-beneficial treatment. So I think this is best captured by what is understood to be good medical practice. And Holly, I might ask you just to reflect on what good medical practice means from a legal perspective.
Sure, thanks, and really appreciate the opportunity to be involved this evening. So It is a defined term in Queensland in both the Guardianship Act and Administration Act and also in the Criminal Code. And I'll talk about the Criminal Code a bit later on. But really, it's, having regard to the medical, recognised medical standards, practices and procedures, and also the ethical standards. And then the term healthcare is also defined to include situations where, withdrawal or commencement of a life-sustaining measure might be inconsistent with medical practice. And I guess more broadly, it's important, while the guardianship legislation is applicable only when an adult has lost capacity, this concept, I suppose, is important also in at later stages when, for example, an adult might sue the health service for medical negligence later on down the track. So these are sort of terms that appear not only in this guardianship legislation, but also they apply later on if in the event we do have a claim against the health service.
And I think that's an important point to note, and also the fact that it doesn't always involve doing things. And as surgeons, we're quite proactive as a group, and sometimes good medical practice involves actually not doing something. And I think that's important to recognise. Do you want to touch on what we understand to be life-sustaining measures?
Yeah, so these are things like artificial nutrition, hydration, some other resuscitative efforts. I guess the point here is that consent is not always required. I've seen it quite a bit, for example, in the context of, say, eating disorder patients who are refusing, say, artificial nutrition, and they don't have capacity because their brain is starved, and so this the provision of artificial nutrition in that scenario is obviously consistent with good medical practice because they don't have capacity. We need to save their lives, and so if it's an acute sort of situation like that, the commencement or continuation of that sort of measure is allowable without the patient's consent. I mean, consent is always the preferred option. However, that's just one example of when these measures can operate without consent.
Okay. Now, we'll just move on and touch on a few cases, and I might bring Michael into the fray here. It should be noted that the cases that we'll touch on today provide a stimulus for discussion. The cases themselves have been redacted to ensure some elements of confidentiality, but they do serve a purpose in terms of stimulating discussion regarding around some aspects of futile care. So we'll begin with case one, Michael. We've got an 82-year-old chap who's presented to the emergency department with abdominal pain. He's got a long and severe history of chronic obstructive pulmonary disease. He's known to community palliative care already and has a relatively long history of chronic back pain with opiate dependence. Sadly, his abdominal pain has been objectified on CT, which demonstrates what appears to be a diverticular perforation. And he has deteriorated relatively abruptly even since being in the emergency department. So I'm sure this is a situation you've come across in the past. How would you proceed in this situation?
Yes. Yeah, many times. So absolutely you want to go assess and see the patient and know what's happening. You can almost imagine what they look like, oxygen, extremely frail, not someone who you would want to jump in and do an operation on. But you need to do the right things. You've got to discuss with the patient, you've got to discuss with the family, next of kin, EPOA, and see what their expectations are. What do they actually want to get out of this episode of care? What their living situation's like, where are they actually placed at the moment? Are they nursing home, bedbound, unlikely to make meaningful recovery despite any best effort you have? And obviously in the specific scenario, the likelihood of the need for a stoma via a Hartmann's procedure is extremely high. Therefore, you need to make the discussion early about what and how do they want to survive? As in, even in a best case scenario with a stoma, they're not likely to be heading back home. They're going to be nursing home placement. And so the early options need to be discussed between, is this surgery going to be something that will help your quality of life, or is palliation early a better option for them? And yeah, we very much experience this on a daily basis. And apart from just looking at the clinical frailty, you can use different, scoring metrics and things like that to help guide the conversation. But ultimately, it's how the patient and the family, want things to proceed, and what you think their sort of risk is going to be of getting the outcome that they want.
I think one thing you mentioned there was expectations, and I think that's really quite important, because often people in the community have a somewhat skewed perception of what this means for them and what the future holds. And I guess it's our job to try and paint that picture for them in relatively trying circumstances for both the patient and the family. So if we move on and see what actually happened in this case. So the treatment options were discussed, and including palliation, which seemed entirely appropriate. The family, however, insisted on surgery. And Holly, I might just bring you in here. How do we capture this notion of capacity, and how does the family involvement in this decision-making impact on the clinical decision-making?
Thanks, Justin. Yes. So I guess for me, the first question is whether or not the patient, him or herself, has capacity. And if so, what are his or her wishes? Because that is really the guiding principle here. Yeah, and if he or she has capacity, it's really up to that person to make their own healthcare decisions about what they want based on a conversation they have with the clinician. If the patient does not have capacity, then I mean that's a different conversation. But it's I think it's really important to, I recognize, particularly when we have older patients and things, that that capacity, there's perhaps less of a presumption of capacity in the more elderly cohort. But however, it doesn't mean we don't have to do the assessment of capacity ourselves, ask them what they want, and then then talk to the family. It's critical that their autonomy and dignity is respected, at the outset. Family can have their views, that's fine, but if the patient has capacity, then it's a matter for them to make the choice.
Okay, excellent. We'll touch on these issues of capacity in a bit more detail shortly, but we'll just move on with the case. So on this occasion, it would appear as though that surgery was undertaken, and a Hartmann's procedure, as Michael alluded to, was undertaken. However, the patient continued to deteriorate in a critical care environment and was then palliated shortly thereafter. So this case was significant so much as that we got quite a good case review from one of our QASM reviewers, and they mentioned lots of useful things. Now, the first port of call with all these cases that come through the audits of surgical mortality are for the individual or index surgeon to reflect on the care that they provided at the time. And interestingly, the surgeon commented that surgery was unlikely to improve the quality of life and was likely futile. So it's clear that the surgeon in this case had some insight into how things would potentially pan out. And when the reviewer went over this case, they quite usefully made reference to LDAC. And if you're not familiar with end-of-life directions for aged care, and this may be a little bit Queensland centric, but these guidelines are available to everyone, and they are quite useful in terms of objectifying and crystallising some of the principles upon which good medical practice are based, particularly when it comes to end-of-life decision making. And as articulated, health professionals have no legal obligation to provide treatment that's not in the person's best interest or would be inconsistent with good medical practice. So there's a good reliance on the legal principles within which we practice, which is useful to note. And it goes on to state that a person and/or the substitute decision maker cannot require or demand that a health professional give futile or non-beneficial treatment. So I think at times, and Michael, you may be able to comment on this, sometimes there's a fear that potentially we're not doing the right thing, be it in the eyes of the patient or even the legal framework. And sometimes that drives the decision making in terms of operative intervention. Would that be a fair assessment, Michael?
Yeah, and I think you're exactly right. There's sometimes there couldn't be a perceived fear of the family being so upset that they proceed down the route of, complaints and OHO and litigation against what they perceive as, phrases like not giving it their all, and or one of the more recent ones I saw from some reviews was, they'd be willing to die on the table versus, just being palliated, which always struck me as very confronting, that no surgeon ever wants that to happen. So that's not something that we would ever endeavour to do.
And the reviewer goes on and comments that the decision to provide surgery is multifactorial. It's a very complicated situation that we come across. And in this case, the surgeon appears to have determined that intervention was futile, but they proceeded anyway, potentially because of some of those issues that we've raised. So at times this can seem the path of least resistance. And as we all know, there are well-described downsides for the surgeon, patient, family, hospital and healthcare system and society at large. And Holly, these situations are difficult. And I think at times we fear doing the wrong thing in the eyes of the patient and the family, but there seems to be a bit of a flux in terms of the pendulum. And sometimes we're getting into territory where at times we can fear doing the wrong thing in the eyes of the system within which we work. Do you think there's ever going to be a legal situation where clinical decisions are challenged by hospitals and health sectors in terms of doing the wrong thing in the eyes of the system in the way in which it's set up?
Look, I think the system recognises that these things are complex. There are multiple sources of external scrutiny, as we know, be it the OHO, be it the coroner's court, be it APRA, be it the media and the ministerial sort of the 24/7 news cycle. I'm not suggesting for a moment that those external processes aren't complicated, but I think there's very clear and established sort of frameworks and guidelines around the system having your back, essentially, in these complicated scenarios. It's recognized that, these are not easy decisions. It's recognized that the family members, put the pressure on, clinicians to do whatever they can. But I just want to reinforce, if a patient has capacity, it's not for their family members to be trying to sway them at all. It's their decision. And, even if they don't have capacity, I think the following slides talk to this, but there's very clear principles that the substitute decision maker needs to have regard to in making decisions for that person. Which includes taking on board the advice from the treating team, i.e., is this futile? They have to have regard to that. So I think as long as we've, stepped through the process and covered off these, key discussions, then, there's no guarantee external scrutiny won't later come. But we've got the sort of clinical documentation to back up our decision making and our conversations, then 9 times out of 10 we'll be okay.
And I guess, again, it speaks to that issue of good medical practice, trying to do the right thing for the right reasons within whatever context you come across. And that should be enough to justify your decision making and defend you later on should that be necessary, but hopefully it won't be. So if we move on and look at some of the medico-legal considerations here, Holly, do you want to speak to this slide?
So I think, the first thing I'd say, and the law backs this up, and certainly there's a presumption of capacity. So, but again, there's capacity fluctuates, as we know. I wondered when I first saw the scenario whether the opioid dependence was a factor. I mean, may or may not have been. And then, even if it perhaps was, and the patient didn't have capacity, it's then the statutory health attorney, and we'll go through this a little bit later on. But the statutory health, so the family members they're not automatic as a decision maker. They're not the default. We have to be turning our minds to some other key documents and things that the patient may have in place. But assuming those documents aren't in place, and it is the statutory health attorney, they need to be making decisions which are consistent with legislative principles and guidelines as set out in the Guardianship Act, certainly in Queensland. And I've included some links there to the general principles and the healthcare principles. And we've talked about the healthcare principles on the next slide, Justin. But they're really key things to be, those fact sheets are quite good to help guide these conversations that we're having with families, because they need to, like I said, have regard to the information that they're being told by treating clinicians. This is not in Mr. Smith's best interests. He's at high risk of death. What are the risks? What are the benefits? They need to be listening to clinicians. That is really the message here. They need to be listening to you, and having regard to the patient's best interests. They really stand in the shoes of the patients when they're making these decisions. So they have to be listening to clinicians, taking that on board, consulting with other members of the family about, what's proposed. It's very clear. And if they're not, if, for example, we think as a health service that, say, somebody who's appointed as a formal guardian for a patient is not acting consistently with these principles, that's when we might, for example, say to the team, you might need to go off and get someone else appointed or whatnot. These, it's really, really important that they listen to the treating teams about what is or what is not good medical practice, having regard to the prognosis.
Yeah, and certainly over time, things really have changed, and we're no longer working in an atmosphere where doctor knows best. And for the most part, that's a good thing, but it now means that instead of deciding what's going to happen, we're obliged to provide a range of options for patients and families and the decision makers in terms of what should be done. And then I guess it's our job to try and counsel them such that they can make effective decisions, often at quite trying moments of their lives. So, Michael, we'll move on to case 2. You're on call in the hospital, and you have a 79-year-old chap who has a syncopal episode, a fall and a head strike. He's admitted to your peripheral hospital, initially with a normal cognition, a GCS of 15. The CT brain demonstrates what appears to be a relatively small subdural. But unfortunately, the GCS drops, and repeat imaging demonstrates progression of this subdural hematoma with mass effect and hydrocephalus, and it's expanded fairly rapidly. And you quite appropriately consult with neurosurgery in the quaternary centre. And the comment comes back that, any further intervention here is likely to be very dangerous with a high risk of death and quite likely to be futile. How would you deal with this situation?
Yeah, this is one that we are faced with, and certainly being in peripheral locations, it does come up, and seeing some of the problems that sort of get reported through QASM as well. It is a bit of a problem. So it's obviously a high risk patient. It's high risk for a couple of reasons. It's someone who's likely going to have a very poor outcome, but it's the challenge of being somewhere peripheral and trying to make peripheral decision making, like from a quaternary center. So they often suffer from the issue of trying to make a remote decision about something they can't intrinsically manage themselves. So it often results in a situation where transfer and palliation can sometimes happen, or then transfer with you know, kind of the onus of performing an operation, even though it might not be in the patient's best interest because it is futile, either at the initial point or by the time they reach the other center. So it's,
And
yeah, just very, very hard.
it's difficult. And to make it even slightly more difficult for the clinicians involved, this individual is somewhat of a linchpin of his family and has a very large extended family with many cultural considerations. In this day and age, it's quite appropriate to be able to or have to consider the cultural wishes of the patient and the family. Are there any things you could employ, do you think, that to help with decision making in these sort of specific circumstances?
Yes, there's a myriad of different sort of considerations that can come up, and it depends on the exact cultural background. So, from the Aboriginal perspective, we obviously have a lot of Aboriginal layers and officers who come in and help, particularly surrounding complex family matters. And in smaller centres, it can be really hard because people can even work in the hospital who then know the patient and have complex overlays. We often deal with Jehovah's Witnesses as well, where we have to bring in members from their community to work out exactly what, obviously not blood product, but certainly some varieties of blood products sometimes can be allowable. And then there's even more specific cultural considerations. We had one recently where the patient had to be buried with all of their organs in place, so they impacted on surgery. Yeah, greatly.
Yeah, so again, these are things that are extremely important and they need to be recognised early so we can help facilitate wishes. In this case, the family is employing or imposing quite a lot of pressure to proceed with intervention, despite advice that it may well be futile. And the high risk of futility of surgery were emphasised yet again, but the family once again strongly insisted on intervention. And Holly, you've touched on capacity numerous times, and that would appear to be an overarching theme this evening, because it's important, I guess. But in this situation where capacity would appear to be lost by virtue of a drop in cognition, we're then reliant on the legal decision makers to help make decisions in this context. We'll move on a little bit, however, and in this case, the patient was transferred for immediate emergency surgery. And Michael, you're not a neurosurgeon, but I'm sure even you can appreciate that this is fairly aggressive intervention for the problem with a craniectomy, decompression, and partial amputation of a cerebellar hemisphere. So obviously we're in extremis in this scenario, and not unexpectedly, the patient does not survive through this. Brain death is confirmed and palliation ensues. So the reviewer comments in this case were appropriate in so much that the decision to operate was made by the surgeon, and there was a lot of emphasis on this significant family pressure, both through the case form written by the surgeon themselves and also on review of this case. It was obviously quite a challenging scenario, with the ultimate outcome expected given the neurological condition of the patient. So obviously a difficult scenario, and again we're dealing with what would be futile intervention. So if we again just touch on this issue of capacity, Holly, why don't you take us through this?
So again, I guess just reinforcing the comments I made before that, yeah, I mean, we've got to presume capacity unless there's been a fairly, clear, a drop of 15 to say GCS 3 or whatnot. That's pretty clear that the capacity's gone. However, the presumption at law is there that they have it. And then again, sort of really the family need to be listening. I as a lawyer in-house, I find it probably a bit difficult to understand how those conversations might flow, but a really clear message that, this is not, I understand you want us to do everything for the patient, but it's not going to result in the outcome that you think it is. It is actually going to be counterintuitive. It is not consistent. Like really, in a good sort of supported way, those firm conversations that this is not in his or her best interests. it's certainly not in the best interest of the treating team. It's not in the interest of yourself as the families, and you know, asking them to consider what do you think the patient would have wanted in this situation, because it's their wishes that are key, and they would have had, if they've got capacity, the right to refuse such an invasive surgery. Yeah, I mean, I don't know what sort of guidance I can give you. I suppose they're difficult conversations to have, but look, and I understand the pressure that the clinicians feel. Like, it's really, really hard, I think, and particularly when the families are quite articulate and they've got perhaps a level of sort of clinical knowledge or whatnot within the cohort. That's even harder. But I just want to reinforce that they have to take your advice. That's a duty they have as a statutory healthcare attorney. They must do that.
Without dwelling too much on this specific case, at the end of the day, if you as a clinician deem this intervention to be futile, with no realistic hope of a positive outcome in any way, shape or form, the law will side with the clinician in terms of that determination.
Yeah, definitely.
Okay. If only it were that easy. But obviously these cases are challenging. And that's for good reason, so we can sort of test the waters to some extent. But these are real world scenarios that we have to deal with. So we'll move on to the next one. Michael, I've got another challenging case for you. We've got a 59-year-old chap who's had multiple prior admissions for bowel obstructions and electrolyte derangements on a background of some mental health issues. And over numerous presentations in the past, the patient is often refused intervention when in an orthodox world it would be considered appropriate. And as we've observed numerous discharges against medical advice over an extended period. And on this occasion, would appear as though the patient has been admitted with what looks to be a large bowel obstruction on the presence of a potentially a mid-sigmoid neoplastic mass in the colon. Once again, the patient isn't keen to engage as we'd expect and refuses levels of care that would normally be employed. However, eventually agrees to undergo a sigmoidoscopy, and a small stricture is found. It looks benign. So in this case, things don't look great, but they don't look catastrophic. But because the patient wasn't terribly keen to engage as we would normally expect with things like a nasogastric tube for a prolonged period of decompression, we witness some element of periprocedural aspiration, respiratory failure, and an ICU admission then ensues. And with a rapid deterioration, unfortunately, the patient succumbs. Now, again, I'm sure you face scenarios like this where the decision making isn't quite as you'd like it to be in terms of the patient being a willing recipient of the advice you give. Can you reflect on this case and the challenges that it presents for the clinician?
Yeah, so there's a lot of problems that kind of result from this with patients who sometimes don't want to accept any care, which is somewhat easier in some ways because then you assess them and allow them to have their autonomy. And if they're compos mentis, then that's an easy option because you say, fine, well, you don't need to accept care, so you can be on your way. The partial acceptance of care opens up to risk. And I think that's what this shows, that when we don't have a complete buy-in from the patient, that there are more complications that can happen. And I think when this is the scenario where it's clearly a person who has had repeated episodes of not wanting to engage, then it's important to involve the other people involved, their EPOA, their other decision makers, whoever might be around, to kind of ensure that this is going to be something that the family, if, as in this case, the outcome happens where the patient dies, that they can see that all measures were appropriately taken and this ultimately respected their autonomy. Because and particularly first, she maintained her decision making, I guess, over a period of time, so she was able to maintain, communicate, and acknowledge it. So in some ways, they respected it to some extent.
And again, we're faced with this issue of capacity, and this is an interesting topic. And Holly, I just bring you to the final point on the slide here. Who can actually determine capacity?
So it's a healthcare professional. So yeah, the legislation is not specific on who can do this. I mean, I can understand that, you know, the preference to have, say, someone from CL Psych or whatnot involved in that assessment, but you know, yeah, just to reinforce that it is something that you as surgeons can do, and you know, particularly if it's a semi-urgent situation, you know, if it is urgent, not, you know, you don't need consent, but if if it is a non sort of life-threatening situation or subacute situation, then you can make that assessment yourself. You can, and you know, particularly if it's escalating and getting a psych in the room to do that, it's going to prolong, you know, what needs to happen. Then yeah, I'd suggest that definitely can be done by yourselves for sure.
And if we deem that the patient doesn't have capacity, where do we go next?
So the first thing, there's a real hierarchy of steps. So the first thing to ask yourself is there an advanced healthcare directive for the patient? You can ask the family member, you could ask social worker to chase it up. If the answer is no, or you're not sure, go to question 2. If there is one, and it's, you know, you don't really need to be turning your mind to validity at that point, but you can always come to legal if you're, you know, worried. If there is one, that takes precedence. Your treatment has to be guided by that document. If there isn't one, or you're not sure or whatnot, then are there any sort of orders from QCAT appointing someone as a formal guardian? Like, you know, maybe it's a spouse, a sister or a brother or something like that. Again, if you're not sure, then is there an EPOA in place? And again, if you're not sure to the answer to that question, then and only then does the statutory health attorney come into play. And then there's underneath, as the next slide will show, a further sort of hierarchy of who is the attorney in order of precedence. So we see this sometimes in dealing with deceased bodies, but it shouldn't be the default. The statutory health attorney, I know it probably quite often is, but it shouldn't be the default. We should be turning our minds to those other key documents. Probably, I think, is less likely QCAT orders are in place unless it's someone who's had a fairly extended history of fluctuating capacity and problems managing their own finances. But certainly 1 and certainly 3 will be key questions to be asking. Are these documents in place? And if yes, the treatment needs to be guided by those documents.
Okay, and again, a good advertisement for advanced health directives in terms of making sure that things are put in place to provide clinicians with some guidance as to what to do in these scenarios. And just on that, when we're having trouble identifying where the paperwork is there any obligation for whoever drafted that paperwork to keep copies?
Yeah, so if you're, for example, a signatory, like if you've been appointed as a power of attorney for health and or financial matters, you should be having a copy of that document easy to hand. It's a very, these are not responsibilities you take on lightly. They are big decisions. They come into play, particularly in a financial perspective, in the sense that, you know, a person's lost, say it's an elderly person, they've lost capacity, they've finished their acute medical inpatient stay, they need to be discharged to a nursing home or respite care setting. The financial attorney needs to make those decisions. They need access to bank accounts. You know, these are not decisions that are made lightly, and therefore they're ones that carry a high degree of responsibility. And like I said earlier, for health matters in particular, there are, you know, very important principles that a health attorney needs to have regard to in making their decisions. And if they're not doing the right thing, that is when, QCAT usually gets involved and steps in and appoints someone they believe will do the right thing.
Yeah. And there's a little bit of chatter on our feed here, and an unknown user has made the comment, QCAT decisions are often drawn out. I tend to agree.
Yes.
And often not at 3 a.m. They're not going to really be very helpful, are they?
No.
But
No.
I guess there's a time and a place. But I guess it's also important just to reflect on the fact that legal people like yourself are readily available for the most part. And when there are problems, often our legal friends are quite a good resource. And I don't think that's terribly well acknowledged or employed in the system as it stands. So I think a good opportunity just to promote the fact that the legal people are there to help us for the most part.
We are here. We are on your team. We're on your side. We have a lawyer on call Monday to Friday between business hours. I've got a mobile number that, if it's after hours, I will try to get to. If not, obviously you've got the DMS or exec on call, but we are absolutely on your side and here to help you with any of this sort of stuff, for sure. Yeah. So, yeah, got dedicated people here to help.
So you mentioned this standing in the shoes of the patient way of looking at things, and I guess that's what the statutory health attorney should be doing to help make decisions when individuals can't make decisions for themselves. So do you want to touch on who is a statutory health attorney?
Yeah, so there is a hierarchy again. It's the spouse, if the relationship is close and continuing, and then the spouse is defined. That includes same-sex, couples and things. So that's in a different piece of legislation. If anyone wants guidance about that, happy to flesh that out a bit. But then if there's no spouse, it's a person who's over the age of 18 who's got care of the patient. Now, that is someone who might, for example, provide sort of domestic care, say a daughter or a friend coming in, to provide care in the home on occasion. It's not someone who's, an NDIS, a paid NDIS provider coming in to do that stuff. They cannot make decisions. And then if there's neither of those, a close friend or a relation. And then as a last resort, if you've had no joy, you can't find anyone, the public guardian is the other option. But I would just say that it's a last resort option. If you go to QCAT and, one of the first questions QCAT will ask is, if it's not the public, who else is available to assist this adult? And it's really, they're looking for someone who's, going to have the best interest in mind. Obviously when there's disputing families, that's a bit different, but public guardian is a last resort option. Yeah.
Just another quick comment from the audience. I find that advanced healthcare directives can be so generic that they're not entirely helpful. And most only say no CPR and prolonged intubation, which doesn't preclude surgery. I tend to agree that at times they are very generic and they don't really give us a great deal of detailed advice in terms of what to do. Do legal professionals receive much training in terms of drafting these documents?
Good question. I think a lot of them, the AHDs are on, specific templates which can't necessarily be altered all that much. I think you'd probably have more joy with an EPOA, but again, depending on how well it's fleshed out in terms of what the patient does and does not want in terms of interventions. Yeah, look, I completely agree. They can be helpful or perhaps less helpful. It doesn't mean, though, that we shouldn't be turning our minds to their existence, because ultimately they will at least highlight, the patient wishes at a point in time. And, if they're valid, and there's issues with the family, for example, they are a way to kind of effectively put the family to a side, so to speak, and say, well, look, I'm sorry, you've got your views, but just want to point out the patient's expressed his or her wishes in this particular document. And you've got to give, the law says you have to give precedence to that. So yeah, AHDs, yeah. And then we've got this other thing, statement of choices. I mean, they're not, I don't rely on those. Can I just say they are not legally binding. They're very sort of, one of a better word, sort of fluffy around, what music a person might want to hear at the time they're dying and things. They are not legally binding. Those. So whereas an AHD or EPOA will be, But yeah, I do look, in answer to the question, what training do myself and my team don't get trained in drafting these documents. We don't draft them. Other lawyers in the community will review them and sign off with them. EPOAs, I think, have a bit more flexibility in terms of what the content is. I'm not aware that AHDs do, but yeah, I mean, if you're doing any sort of estate planning, care planning, as a lawyer, you really should be, I would think, having some level of sort of skill and understanding of what the end of life type scenarios could be, for your client who's being asked or signing one. Yeah.
No, reference to the statement of choices, I think it's quite useful because we do see that now increasingly, and I've often looked at it and wondered what that means in terms of where we stand legally.
They don't have any application from a legal perspective.
Now, you've touched on the fact we're quite lucky in the area in which we work, and I'm sure these services are replicated across the country to some extent. So probably worth looking at your own jurisdiction in terms of what is available to assist. So there's just a couple of questions, many of which we've discussed already. Who can decide if treatment is futile? What do you think, Holly? The clinician?
Yes, definitely. Yes.
And there was a question on the feed here. What if the surgeon and anaesthetist disagree about whether or not to proceed?
Look, I'm aware this comes up. I think that is a situation where, again, you'd be looking at any sort of guiding documents from the patient themselves, or what the families, as statutory healthcare attorneys' views might be. I mean, I probably don't see it so much in a surgical setting myself, but look, I'd be inclined to sort of escalate that to the DMS, exec on call. Legal are always happy to assist with these things. If the decision, or so are you saying that, say, the anaesthetist wants to proceed and the surgeon doesn't, or is it the other way around?
It's usually very much the other way around.
The surgeon wants to proceed and the anaesthetist doesn't?
Well, yeah. I mean, without being too...
Yeah.
Yeah, Michael would agree. Yeah, usually the surgeons are very keen to try and save the day, and the anaesthetists are stopping us from doing so. But that's usually because they've got a great deal of insight into the fact that the patient's clearly very unwell and they may not survive through to the end of the operation.
And I think that's, look at the ASA and depending on which sort of hospital we're talking about, like what the ASA sort of risk is and things. I mean, it has come up from time to time, in the more sort of rural settings that I've been aware of. But look, I think
it's clearly quite difficult.
Look, it is.
No, but I think
if there's anaesthetic, if there's like if this is not a fit and healthy young person that you're proposing to do a fairly high risk surgery in, and depending on what the post-operative care setting is, have you got an ICU? Have you got an HDU? If the answer to those sort of two questions is no, and you're going to be reliant on, say, inter-hospital transfer to a tertiary, I can understand where the anaesthetist is coming from, to be honest, because, I mean, as we know, GA is a very risky thing in itself, particularly in non-fit and
Yeah.
healthy.
Well, I guess one thing that has been useful, depending which way you look at it, is the advent and explosion of perioperative medicine, where we've got more clinicians involved than ever, looking at end of life type decision making, particularly in challenging circumstances like those we've touched on this evening. So, again, one comment on the feed just relates to whether or not having multiple opinions assists in terms of be it decision making at the time. For instance, if you ask a colleague for an opinion, if you're not quite sure what to do, does that hold any weight in the eyes of the law, having multiple expert opinions, as it were?
Look, from a purely legal perspective, I don't really think so. Look, what I'm thinking probably more in the sort of coronial sort of space, like that kind of jurisdiction. Yes, definitely there's benefit in an MDT sort of approach to these things, and like that sort of adage, more minds, get three brains in a room, then it's better than one. But I think usually the way that from a legal perspective, saying PIPA claims and things, they're looking kind of more broadly at the sort of admitting surgeon, the consultant, the admitting specialty. But I do think absolutely that has to be we don't work in silos. We nor should we. I think there is absolute benefit in an MDT approach to these things because of the holistic and unsiloed world that is and probably should be medicine. We can't do we don't work in a vacuum of specialties, nor should we.
We've started a small war on the chat, so we'll try and move on a little bit. We've discussed some of these issues already in terms of futility and decision making, and how clinicians should proceed if decision makers disagree. These are all complicated issues. Now we'll just briefly touch on this to round things off. It is obviously a bit of a contentious issue, and it would appear as though this hasn't really manifested in our local environment. Certainly overseas, there's been issues to do with what is labelled medical manslaughter. Do you think that's something that could come to our shores?
I think it's very unlikely because we've got a well-established legal framework for how patients who are unhappy with their care can essentially pursue us as a health service. We've got very well-established guidelines for indemnity for our doctors and nurses if they were to be named as an individual respondent to a claim. So those two pieces of legislation, certainly in Queensland, are the guiding legislative framework. Essentially, they have to prove certain elements to get a claim up. So basically, you have to establish that a duty of care is owed to the patient. Now that's easy. It's never without sort of question. And then you have to then show that that duty was breached, and then the breach caused the personal injury that and then damage to the patient. So and those sort of things work their way through during the life of a claim, but it's really important to remember that in Queensland in particular, as a clinician working in a public hospital, in the course of your public duties, liability does not attach to you as a individual. It attaches to the state. So if in the off chance that you are served with a claim in your own personal capacity, please contact me or my team. We'll help you to apply for indemnity as you're entitled to apply for under the relevant guideline. And then, that process will work its way through. the state or Metro South could only then seek to recover legal costs from you associated with defending the claim if it was shown you had acted with, in any other way without good faith and with gross negligence. So very high bar. You will be covered, of course you can, have your MDO membership and things like that. But 9 times out of 10, I find that quite a few of them come back to us as legal and say, hey, what are you guys going to do for this doctor? And that's when we'll turn around and say, hey, apply for indemnity, to the CE, and if it's signed off, which it usually is, you'll be covered.
And what are the mechanics of these claims being made? Like, how does that work?
So really, it's an initial notice is what we get. We get a Section 9A notice, puts the health service on notice that they're going to sue us. At that point, we disclose the records and anything else we think is relevant. We lodge the claim with our insurer, who's the Queensland Government Insurance Fund. They will then appoint a panel firm. There's, a number of top-tier law firms that are on the panel, and then they will manage the claim going forward. And there's then periods of time, say 12 months, they have to support it with a formal notice of claim. That's really when it becomes sort of real. They've got to then provide evidence, medical expert evidence from an independent professional, be it surgical, orthopedics, whatever the specialty is, to support their claim. And then it sort of proceeds through the statutory process. There's various documents and things that needs to be exchanged and disclosed throughout the life of the claim. But most of them settle out of court. That's the whole point behind the personal injury regime in Queensland, to keep things out of court. I think, to my mind, personally, the flip side of that is that we've perhaps seen quite a few claims over the years settle when perhaps breach is not established, certainly causation is not established. So I've got my own sort of views about that. But look, I just want to reinforce the fact that you will be covered. Clinicians should never be getting named in these proceedings on an individual level. It's the health service. Liability attaches to us, not to you. And we can only claw back legal costs, not that I've ever seen it happen in over 10 years, if you say were to be drunk while operating, or doing something really, really quite wrong.
Okay, and if we just skip through to what constitutes criminal liability.
So again, this is a defined term. Well, this concept of negligence is captured in our criminal code, and again, so for this reason, I think it's unlikely that we would ever see, certainly in the public setting, individual doctors, pursued under the criminal legislation, because it clearly says that if you're performing, a surgery with good faith, with reasonable care and skills, then liability won't apply.
And as you say, like, it again boils down to good medical practice in many ways, doesn't it?
Yeah, absolutely.
So we're getting close to time now, and we might just wrap up by just reiterating that futility is the absence of benefit, and treatment futility specifically is when treatment doesn't achieve the intended goal. It's important, obviously, we need to establish capacity, and that probably wasn't something I used to think about as an independent entity. You just sort of do it in passing, but I think this has really forced me personally, and Michael, you might agree with this. In fact, you have to, because I'm asking you to. That
Actually,
capacity is it's obviously a significant issue, and it's important that we establish that early on with patients. And if that's lacking, then we need to go down that pathway to establish who can be the legal decision maker in any particular context. So there we go. Identify and engage the decision maker, and define the goal in terms of what we're trying to achieve, because ultimately a bad death is what we're trying to avoid. So Holly and Michael, I'd like to thank you for your time today. Thanks so much for providing some legal insights, Holly, and Michael, I hope you didn't mind me poking you a little bit and putting you in some awkward situations, but you know, they're real scenarios that we come across every day. And I'd like to thank the audience for participating and providing us with a few useful comments along the way. And the chat continues. If anyone's got any pressing questions, do speak up before we call time. But Holly and Michael, have you got any final comments?
No, thank you so much. Really, really appreciate the opportunity to be involved. You know, very happy to be involved with these sort of things going forward. It's so important, you know, and for those on the call who work for Metro South, please reach out. Me and my team are here to help you. We're on your team, and yeah, very happy to provide for the education and things as required as well. So thank you so much. Really do appreciate it.
Yeah, thanks so much. It was really good. Yeah, very enjoyable.
Oh, it's just nice to know that the legal people are our friends and not our enemies at times.
Absolutely, yeah.
Which is nice. So let's all stay on the right side of the law and do the right thing by our patients, families, and our colleagues. So once again, Holly, thanks so much, and Michael. And thanks once again to the Audit of Surgical Mortality for providing this forum this evening. And on behalf of QASM and NTASM, thanks so much for being with us this evening. And without further ado, we'll call our webinar to an end. So thanks so much.
Thanks a lot. Bye.